Ready?
Yep. Yeah. Thank you, Nina. Hey, everybody. Good morning. I'm Thomas, for those of you who I haven't met. And first of all, just a big thank you to Celia and Cooper, who gave a couple of great talks this morning. Today, I'm going to be talking about screening for and prevention of falls in the elderly. So I think this is an important topic for reasons that we're all familiar with. Just that falls are common. They're associated with morbidity and mortality in the elderly. So I wanted to do more of a dive into this topic. I am not a geriatrician or a neurologist or really anybody who can speak with authority on this topic. But I talked with Dr. Amy Thomas, who's a geriatrician, and some of her colleagues, and did a bunch of reading, and I'm excited to share with you guys what I learned. So let's see. Yeah. First, just the burden of falls in the elderly being patients over the age of 65. So unintentional injuries are the seventh leading cause of death among older adults, and falls are the number one cause of unintentional injuries. There's also significant morbidity and loss of independence associated with falls, and especially injuries that are sustained as a result of falls. So serious injuries that we often think about are things like hip fractures, traumatic brain injury, cervical spine injury, and these can result in functional limitations, fear of falling in the future, activity restriction, and social isolation. And kind of this vicious cycle that can put elderly patients who are fallers at increased risk of things like depression, and then also becoming institutionalized, being in a nursing home or assisted care. So a little bit of epidemiology: approximately 1 in 3 patients over the age of 65 have fallen in the last year. So it's near certainty that patients on your primary care panels are falling. And only about 50% of those patients who are fallers report falling to their providers. And about 20 to 25% of fallers are kind of repeat fallers. And these are the patients that we're trying to identify and do the things that we can to keep them safe. So my learning objectives are to talk about who to screen, how to screen, and kind of briefly why we screen. It's kind of self-evident, but I'll talk a little bit about kind of the evidence behind the screening tools that we have. Then I'll talk about the risk assessment. So in patients who screen positive, the things that we do to identify those intrinsic fall risk factors in our patients, which is really kind of our role as part of a multidisciplinary team working with these older patients. And I'll talk about some frameworks for thinking about fall risk factors. And then towards the end of the talk, we'll talk a little bit about interventions, things that we can do that are evidence-based and can help reduce risk of falling. And then I'll stress working collaboratively with physical therapy, occupational therapy, and pharmacists. And as part of that, I talked with a physical therapist, occupational therapist, and a pharmacist who are part of a program called Moving Freely at the VA. And it was really interesting to hear kind of their perspectives, and I'll try my best to share their perspectives with you all. And then at the very end of the talk, we'll talk a little bit about like approaches and tools for deprescribing, although that really could be its own separate talk and would be a cool talk for somebody to tackle at some point. So in putting together this talk, I relied heavily on the CDC Steady Initiative, and I can't remember off the top of my head what Steady stands for, but basically it's an approach to screening patients who are at risk of falling, and then kind of like evidence-based recommendations for how to perform a fall risk assessment and then some evidence-based interventions based on what you identify on your risk assessment. So this is an algorithm that they have put together to help providers have kind of a structured approach to this really common problem. So first we'll talk about screening, and here's a picture of Sherlock Holmes identifying a case. So the first part of this process is screening. So identifying who are the patients where you're going to spend that extra time to do a complete fall risk assessment. So the CDC Steady recommends a couple of different screening tools. And I'd just be curious, and you guys can put in the chat, or just you could say out loud, turn on your mics. Like, what are some questions that you might ask a patient to get a sense of their fall risk? And Nina, maybe if you could give me a hand here. Oh, I got the chat. Yeah. Nice, Rashid. Yeah, great, Priyanka. Yeah, fear of falling. Super. Yeah, cool. You guys are hitting the nail on the head. So yeah, there's a couple of different approaches and tools that are recommended. One is the 3 key questions. This one's great. It's super intuitive. My point with that is that the kinds of things that you guys were putting in the chat are exactly the kinds of questions that are part of this screening tool. So it's falls in the last year, fear of falling, and then feeling unsteady with your feet, or kind of a subjective problem with balance. So that one's really easy to remember and administer. Also, the questions have been shown to have like reasonable likelihood ratios associated with risk of falling, around 2 to 3. And the other would be the Stay Independent questionnaire, which is more involved. It's a 12-item questionnaire that patients could fill out. This would be a good one, depending on how your clinic flow works, to have like your MA or nurse, whoever's rooming your patient, to include that with like a PHQ-2 or any other questionnaires that might be part of the general set of questionnaires that patients get when they're being roomed. And it gives you a little bit more information, and that information can be helpful when you get into the falls risk assessment to guide further evaluation. And then another point that I'll make is just to normalize falls. So like I was saying, only maybe 50% of patients who are fallers report that to their provider. And so part of that, I think, comes from fear of loss of independence and what it might mean to be someone who's at risk of falling. And so I think that just addressing that up front, and saying that your goal is to make sure that you're as safe as possible. Our goal is for you to live as long as possible, as well as possible, and for us to align with your goals. And if that means staying at home, we'll do everything that we can to make your home a safe place for you. And trying to address that potential fear of disclosing information. So this is the Stay Independent 12-question screening tool. And so focusing on some of these questions at the bottom, I often have to rush to the toilet. I've lost some feeling in my feet. I take medicine that sometimes makes me feel lightheaded or more tired than usual. I take medicine to help me sleep or improve my mood, or I often feel sad or depressed. So you can see how like these kinds of questions might drive at or get you going down a path towards specific risk factors for falls, where the three key questions isn't really going to get you there. So Yeah, I think it's worthwhile to think about incorporating this questionnaire into kind of the routine process of rooming a patient. If you know somebody's coming in who you're worried is at risk of falls, I think if we're going to do this added work of like administering these questionnaires and then also like asking the three key questions, screening patients, we want to know that it's worthwhile, or at least I would. And so this was a validation study of just the screening portion of the study algorithm. And it was based on survey data from this National Health and Aging Trends study that included over 7,000 community dwelling adults over the age of 65. Um, and at the time that this validation study was done, the screening criteria that study recommended were a little bit different than they are now. So it was like if you had one fall, and you had evidence of gait or balance instability, kind of an objective measure as determined by the provider, then that would put you into a risk category. Or if you had multiple falls, then you screened positive. And so they had to come up with kind of a proxy from the survey data to get at this like gait or balance instability part of what was used for screening at the time. And to do that, they looked at things like ADLs and kind of different survey data that they could use as a proxy for gait and balance. But then they followed these patients after classifying them as low, moderate, or high risk and collected data related to falls. Primary outcome was falls within the last year. And then the sensitivity and specificity of the screening tests for this primary outcome were both 0.65, which is not great. But based on these area under the ROC curves, looking at the kind of light gray line here, if you can see my cursor, compared with the dark gray line here, the dark gray line includes the risk category based on the steady screening criteria. And then this one includes just covariates like demographics, age, gender, and things of that nature. And so you can see that including the steady screening criteria did improve the sensitivity and specificity, and in logistic regression models, including the steady risk categorization, in addition to other kind of known risk factors for falls like frailty, multiple comorbidities, disability. The steady risk category remained a significant predictor of fall risk. And so that to me suggests that doing this screening process adds value to kind of that information that clinical information that you'd be taking into account to determine whether or not the patient in front of you is at risk of falling. So to summarize the screening part of things, we're screening all adults over the age of 65 annually or presenting after a fall. That's a US PSTF grade B recommendation, which is like you should do it, but it's not mandatory. And then systematic use of a screening tool probably adds value to your overall gestalt as far as risk of falls go. And then I would just pick a screening tool, whichever one seems to work best for you is fine. And then you try to use it as best as possible and incorporate it into your practice. And then this is something that we haven't talked about yet, but pay close attention to elderly patients who are taking antipsychotics, those with dementia, Parkinson's disease, and stroke, in particular patients with stroke symptoms, so who have like sequela from a stroke that's evident on exam, because these things are strongly associated with risk of falling. So getting into the risk assessment part of the talk. So I like this schematic from Clinical Problem Solvers. it kind of gets at that falls are like the result of an interaction between a person, their intrinsic risk factors, and then their environment. So, for example, um, if you have a patient who falls while, doing gymnastics, a young person who's fit and able who falls during gymnastics, that's obviously different from a patient with a movement disorder who falls getting up to make breakfast in the morning. So thinking about kind of the circumstances of the fall and the patient in front of you, trying to identify what are those intrinsic factors, and then what are kind of the extrinsic environmental factors is key to the risk assessment. So this is kind of where we're at in the algorithm. So at this point, our patient is screened positive on either the Stay Independent questionnaire or the 3 key questions, and we're into kind of identifying risk factors for falls and what may have contributed. So at this point, your evaluation is going to start with gathering a history. So here's a case. Imagine a 68-year-old woman with a history of depression, PTSD, migraine, osteoarthritis, and osteoporosis presents to your primary care clinic after a fall in the setting of 1 week of diarrhea and positional dizziness. The fall occurred several days ago. She felt dizzy after standing, describes feeling lightheaded, didn't have loss of consciousness, but she did hit her head and had a bruise on her face over her cheekbone. She does not recall tripping, didn't have any subjective vision changes or subsequent neurologic deficits. And on 3 key questions, she denies previously feeling unsteady on her feet or having any other falls during the previous year. She's got a long med list that includes alendronate, atorvastatin, topical diclofenac PRN for osteoarthritis, escitalopram, omeprazole, Zofran she takes for nausea associated with her migraines, Topamax, gabapentin, prazosin for PTSD, and Tylenol. So at this point, I just ask you guys, maybe put in the chat or unmute yourselves. What are some things that jump out to you from just the history alone that might make you concerned as far as things that could have contributed to this fall, or that might be risk factors for this patient falling in the future? Yeah, awesome. Yeah, totally. Great thoughts, you guys. Yeah, thank you. So here are some of the things that jumped out to me after seeing this patient, kind of thinking about her retrospectively, and after having put together this talk. One is her age. She's in a category where we worry about falls. Also, falls are more common amongst women. She has depression, which can be associated with like cognitive dysfunction and has been associated with falls, also osteoarthritis. And then her osteoporosis doesn't necessarily put her at increased risk of falls, but certainly could increase her risk of having a bad outcome if she did fall. Obviously, the fact that she fell puts her at risk of falls in the future. This positional dizziness that she's having, I think, Andrew, you're driving at that. And then that she hit her head and had a bruise. So I think, less so this patient didn't have any worrisome findings on her exam. But I think just the fact that she did hit her head is worrisome to me, because most people, if they fall and are strong enough, flexible enough, have the agility kind of the cognitive function will fall in such a way that they're able to protect themselves. So that's worrisome that this patient fell and hit her head. I think it suggests that maybe some of those mechanisms that are involved in protecting yourself might not be intact. That torvastatin, thinking about just myalgias, can contribute to fall risk. The escitalopram she takes. So this is interesting. SSRIs have been associated with increased risk of falls, and it's a little unclear because it's kind of like confounding by indication. So like depression alone is associated with increased risk of falls, but then escitalopram and SSRIs in general can cause dizziness, which is one mechanism by which they might contribute to fall risk independently. And I'm not arguing that we take all patients who have depression and are falling off their SSRIs, but it's just something to think about. Anti-epileptic drugs and GABAergic drugs, and then the prazosin, as Kim pointed out, is associated with orthostatic hypotension. And then, yeah, like Nina was pointing out, she just has a big med list overall. And so worrying about drug-drug interactions and polypharmacy. Cool. So this was an interesting paper. It's from JAMA, the Rational Clinical Exam series. It's an older paper now. It's from 2007. But it looked at, what are the elements of the history and physical exam that are associated with risk of falling in patients. So in this review, they looked at 9 studies, and they included studies where patients were followed for like 11 to 12 months, and that reported outcomes, including 1 or more falls or 2 or more falls over that period of time. And then they looked at, the negative and positive likelihood ratios of various historical and physical exam findings. What was interesting was they found a pretest probability for 1 or more falls in the next year among patients over 65 of 27%, which is pretty consistent with that 1 in 3 statistic that oftentimes is cited in the literature. And then the presence of, based on that pretest probability, the presence of any factor with a likelihood ratio of 2 to 4 translates to a post-test probability of around 50%. So based on that high pretest probability, it doesn't take a very strong risk factor to put someone into a category where we'd be concerned. So looking at some of the predictors that they measured, and thinking about our patient taking 4 or more medications, more than 4 medications, this is considered kind of polypharmacy as a predictor. And then having a fall in the last year, likelihood ratio of 2.8. Fall in the prior month is a stronger predictor. That's probably just because if you catch somebody who's fallen in the last month, they may be a frequent faller, just kind of probabilistically. And then this I found interesting: taking a benzodiazepine, phenothiazine. This is like your first generation antipsychotics or an antidepressant, was associated with a likelihood ratio of 27, which would seem just bananas. But then when you look at 2 or more falls in the next 12 months, when you take out antipsychotics, and just include benzodiazepines and antidepressants, the likelihood ratio drops to 1.8, which makes me think that that likelihood ratio of 27 is largely driven by antipsychotics, which may be kind of like a proxy for patients with severe dementia, with behavioral disturbances and things of that nature. And then in blue here, just things that are really strong predictors of falls. So previous stroke, that's evident on neurologic exam, history of dementia are kind of big ones to look out for. So physical exam as part of a fall risk assessment. There's a lot of different systems that are involved in maintaining balance and gait. This is kind of review for all of us, but obviously the visual system, the vestibular system, and the dorsal columns, your proprioception. And then all of this sensory input has to be integrated in order to develop a plan. And then through your efferents, communicated to your effector systems, your muscles and joints, in order to maintain balance and carry out walking. So there's a lot that goes into it, and a lot of places that this can break down. And these systems over time can degenerate. So you might be feeling like Jeff Bridges in The Big Lebowski here. It's really amazing that anybody can stand up and walk. And so thinking about how to go about physical exam in these patients, I think one approach would be to kind of structure your exam based on those different systems that are involved. And then here would be like a proposed framework for thinking about different problems that could contribute to fall risk in a patient. And it's based on that kind of physiologic kind of background. So one would be thinking about the sensory systems, your vision, your vestibular apparatus, and somatosensory systems. With vision, one thing I found interesting was bifocals are associated with increased risk of fall. Bifocals affect the way that your eyes focus on the area right in front of your feet. And then other things that are common in the elderly are things like glaucoma, macular degeneration, cataracts. Thinking about the vestibular system, it's less likely that a patient is going to be like sitting in front of you actively having symptoms of vertigo. And so not much to do there from a physical exam standpoint, but chronic intermittent vertigo can certainly contribute to risk of falls. So these would be things like BPPV, vestibular migraine, Meniere's disease, and then somatosensory, the most common contributors to the problems with somatosensory system in older adults are diabetes and peripheral vascular disease. Then there's integration and planning, kind of your CNS. So there you've got movement disorders like Parkinson's disease, problems with executive function and attention like dementia and depression, hypoperfusion, this is your orthostatic hypotension, strokes, arrhythmias, and then sedation. So this is kind of where internal medicine often lives, and thinking about medications and then toxic metabolic causes of patient being altered. And then lastly, thinking about your effector system. So strength, differential for that is kind of your upper motor neuron, lower motor neuron, nerve root, peripheral nerve, NMJ muscle kind of thing. And then sarcopenia. So in older patients, chronic diseases that are catabolic, like COPD, CHF are really common. And then joints, things like arthritis, decreased flexibility. And then this note in the corner here, just that most gait problems in the elderly are multifactorial, not due to one of these, due to problems in one of these systems. And then among patients presenting to general clinicians with trouble walking, the most common problems are arthritis, followed by orthostatic hypotension, stroke, Parkinson's disease, and claudication. And so that's also helpful to kind of like prioritize what are the problems you're thinking about. So in terms of what to check, I'd recommend checking orthostatic vitals. If you have a blood pressure cuff in your room, one approach would be, this was based on something that I heard in a Curbsiders podcast, and I liked it, would be to get a standing set of vitals. Just have your patient stand for a minute, get a set of vitals, so you have something to compare against vitals that they got while seated during rooming. If you didn't work out with your MSA or nurse to get a set of orthostatic vitals before the patient ends up in your exam room. And then test visual acuity. This is a kind of do as I say, not as I do thing. I can't remember the last time that I pulled out the card to test visual acuity, although I have been more often just reaching for a piece of paper and asking a patient to read something on the page. Test proprioception. Vibratory sense and proprioception rely on the same system, and vibration sense is just a better test than getting down and saying, can you feel me moving your toe up, down? Test vibratory sense, and then performing a Romberg is a test of proprioception. And then, like I was saying, patients tend not to have like acute sustained vertigo when they're in clinic. These patients, thank God, tend to present to the emergency department. And so considering chronic causes of dizziness, there may not be much for you to do from a physical exam standpoint. Obviously, if the patient's sitting in front of you with nystagmus and is reporting vertigo, then you can do like a HINTS exam, your head impulse nystagmus and test of skew. We've all experienced the neurology rotation, and I'd be surprised if any of us felt really confident in our HINTS exam. But in the hands of the right clinician, the absence of test of skew and having unidirectional nystagmus and a positive head impulse test has a negative predictive value of a central cause of vertigo that does even better than an MRI. And so it's something to think about. It seems relatively straightforward to do, but again, less relevant in the clinic setting because patients usually have chronic intermittent vertigo and are not actively symptomatic. And then think about incorporating special tests of gait and balance. I'll talk about that here in a little bit. So one part of your physical exam should be assessing gait. So, thinking about what's common in clinic, osteoarthritis and antalgic gait is something that we'll often see. I'm not going to belabor the point. We've all seen somebody with a limp basically decrease time spent in stance phase over the affected leg. What I thought was interesting though is I hadn't heard about a coxalgic gait, abnormal gait from hip pain. And so the idea here is that when you're in stance phase over the affected hip, your hip abductors have to contract, and when they do that can put like 400 pounds of pressure over the femoral head, and this can be extremely painful for patients with hip OA. And so you can end up with a gait that's kind of similar to a Trendelenburg gait, where the patient will lean over the affected hip and they might stick their arm out over that hip, and the idea is they're trying to move their center of gravity over that hip to reduce the amount of force that those hip abductors have to put onto the hip. You won't see the Trendelenburg sign. So like you'd see in patients with lumbosacral radiculopathy or after a hip replacement, and those muscles or the nerves that serve them are affected, where you have the patient stand on one leg and then the opposite hip kind of sags. You won't see that really, but you can see kind of a similar gait. And then talking with a physical therapist at the VA, a shuffling gait is, in her experience, really common in the elderly. And this isn't necessarily like the shuffling gait that you'd see in Parkinsonism, although it can look similar. So this is more like, imagine walking on ice, the kinds of things that you would do. You kind of like flex all of your joints, you might have a wide based gait, and then you'd spend very little time in stance and kind of take short, low amplitude steps. That's how I think about it. And this is a risky gait just because you're not taking high steps and can trip over things. It's common among patients that have fear of falling just because of that lack of confidence during stance phase. And then lastly, think about proper footwear. So wearing things like flip-flops around the house is a risk factor for falls. So we want to make sure that people are wearing closed-toed shoes that fit well. So special tests of gait and balance. Steady recommends a number of different tests that you can do, and they don't make a strong recommendation for one over any of the others. So your options are the timed up and go or tug test. This is the one where you basically have your patient cross their arms, stand up, walk to a piece of tape or something that you put on the floor that's 9 meters or 10 feet away, and then come back and sit down, and time them from when they get up to when they get back down. So Steady recommends a cutoff of 12 seconds as being abnormal. Anything greater than 12 seconds is abnormal. What was interesting was looking at a meta-analysis, they found that using a cutoff of 13.5 seconds only yielded a likelihood ratio of 1.2. So, and it included 1, so not really changing your post-test probability of whether this patient's at increased risk of falls. And then using a cutoff in another study of 35 seconds yielded a likelihood ratio that was better, but I think that adds little value. Like if you could imagine sitting there and watching a patient take 35 seconds to get up and walk 10 feet, that patient is already at such high risk of falling that a likelihood ratio of 2.6 is just not really adding any value. So it might be more useful is to think about normative values. So patients 60 to 69 on average take about 8.1 seconds, 70 to 79 about 9 seconds, 80 to 99 about 11 seconds. And then kind of compare where your patient's at relative to those normative values. And I think, what's interesting about this test is that it also includes standing from a seated position without using your arms. And if a patient can't do that, that alone has a likelihood ratio between 3 and 4 in terms of predicting risk of falls in the next year. And then you also get to see their gait. So this would be a good option if by some miracle you're running on time in clinic and the patient is brought to you. But if you're like me and you're chronically running 10 or 15 minutes late and you're walking out to the lobby to get your patient, then I think a better, more practical test of gait and balance would be the stop stalking when walking test. And this is super easy to administer. All you do is, as you're walking with your patient, ask them a question, try to engage them. And if they have to stop and turn to you, then that's a positive test. And what I think this gets at is that, walking and maintaining balance is a complex kind of coordinated task that requires some cognitive function. And in patients who feel unsteady, have to focus more on walking, or have decreased cognitive reserves, they might have a positive test. There's a 30-second chair stand. This is where you have a patient kind of sit and stand without using their hands as many times as possible over the course of 30 seconds. This is a good one for telemedicine. You can just have your patient do it right there in front of you. And then there's this 4-stage balance test. Rather than talking about it, I'll just show you. So hopefully this works. Hopefully you can all see my screen.
I don't think we see the video quite yet if it's on your screen already, Thomas.
Okay, got it. I'll go ahead and stop that. So basically what you're gonna do here, maybe I'll stand up and show you guys, but basically what you're going to do is have the patient first stand, feet together, eyes open, and then you're gonna have them stand with kind of the ball of the one toe adjacent to the instep of the other foot, kind of narrowing their base of support, and then a tandem stance, so one foot in front of the other. And then the last thing is you'll have them do like stand on one foot. So that's an option as well. So I notice I'm running out of time here. So unfortunately we won't have time to get through everything. Okay, I'm going to skip over this. This would be a schema for chronic dizziness that's in clinic. So you're more like chronic intermittent dizziness. Briefly, cognitive impairment and dementia, kind of talking about diagnosis and management is beyond the scope of this talk, but these things are strongly associated with falling. USPSTF doesn't recommend screening all comers for cognitive impairment. And certainly having a fall is not necessarily a reason to screen somebody, but just having a high index of suspicion and knowing that these things are strongly associated. And so I think putting it all together in terms of your risk assessment, think about the resources that are available to you in your clinic and how you might be able to accomplish all these things is a worthwhile thing to do. And it's going to kind of depend on your workflow in clinic. But one approach would be to just observe the patient walking into the room. If you feel it's safe, try to engage them and do a stop talking when walking. Gather your fall history. Consider causes of chronic intermittent vertigo and dizziness. And you want to update the med list. Make sure you include over-the-counter meds like your first generation antihistamines, any of your PM drugs, and then check orthostatic vitals. Do your special tests of vision of gait and balance, and then you're basically done. So thinking about interventions, maybe I'll skip here to deprescribing. Actually, I think is probably going to be the best use of the time we have left. So deprescribing, first, here's kind of a general approach that was recommended by the pharmacists I talked with. It's also consistent with recommendations from geriatric pharmacist that was interviewed on Curbsiders. And then there's also various other kind of approaches to deprescribing that you can find in the literature. But oftentimes it starts with updating the med list, making sure you're including over-the-counter drugs, just knowing everything that the patient's taking. Things to look out for, again, as far as over-the-counters or first-generation antihistamines, doxylamine. That's a medication that's oftentimes in those PM drugs. Ensure medications have an indication. Oftentimes things have like a time-limited indication, so those can be easy targets for stopping. And then consider the benefits and harms in the context of your patient's goals. And this is where I think that primary care is really probably the best spot, or maybe in the geriatrics clinic, somebody that's working longitudinally with the patient, has a good relationship with them and knows what their long-term goals are, can really best determine what are, medications that are going to be consistent with those goals. Tools that can be helpful are things like Beers criteria, and then European Geriatric Society put together the Stop Start, which is something similar, but it also recommends medications that should be used in various conditions in older patients, in addition to medications that we should avoid. Prioritize medications based on the balance of benefits and harms, and then deprescribe and have close follow-up. One trick that can be helpful is just asking your patient, what are the most important medications to you? And then what is the medication that you wish you could get rid of most? And that can help you determine, one, what does a patient might actually be taking, and identify problems with like medication non-adherence, but then also help you try and align with the patients in terms of their preferences, because this can be kind of an anxious time for both providers and patients, thinking about taking away a medication that you think might be helpful. There's an interesting article that talks about kind of the ethics of deprescribing, and argues that from the standpoint of like non-maleficence and autonomy in particular, that it makes a lot of sense. So, if you're deprescribing, it's because you're worried about off-target effects, drug-drug interactions, drug-disease interactions. You're trying to do no harm in that sense. Autonomy, patients should be able to decide for themselves. What they're taking is too complex. And then from a justice standpoint, if you think that you're doing more harm than good with a certain medication, and it could be used better elsewhere in a different patient, then you could make that argument too. So I'll just, this I think is an interesting one, and I think I've got maybe 5 more minutes. So let's just go through this case. So this is a 79-year-old functionally independent woman living alone with hypertension, hyperlipidemia, COPD, CKD, OA, osteoporosis, type 2 diabetes for the past 40 years, taking insulin glargine 40 units at bedtime, aspart 5, 7, and 9, and then additional sliding scale insulin. She's been having hypoglycemia, symptomatic with low blood sugars down to the 50s, and excursions up into the 300s. Her A1C is 7.8. So one question that I think we oftentimes come up against in primary care clinic is, what's your goal A1C for this patient? I'd just be curious, what would be your guys' goal A1C for this patient? You guys, just a few minutes. 7 to 8, 8 to 9. Just focus on avoiding hypo and hyperglycemia, or if you need more information. Cool. So pretty good spread. So I would say I would probably need more information. And the reason why is you want to know kind of the severity of these different diseases the patient has. So is this COPD where the patient is on oxygen throughout the day? CKD, 5, can help you decide what are your goals. And this is based on updated recommendations from the American Diabetes Association. So they have different A1C standards set for different kind of degrees of comorbidity. For this patient, assuming that they had kind of like, CKD3 and well-controlled COPD, they'd be in this complex intermediate group. And our A1C goal for them would be anything less than 8, which is consistent with ACP recommendations too, which recommend a A1C goal between 7 and 8 for most patients. For our very complex patients with end-stage chronic diseases, stage 4 CHF, COPD on oxygen, patients on dialysis, these are patients where we just want to avoid symptomatic hyperglycemia. So blood glucose is above 180 to 200, and you'd stop following the A1C altogether. And I'll just briefly point us to this is an algorithm that the ADA recommends for simplifying complex insulin therapy in patients like this who are having hypoglycemia or struggling with a complex insulin regimen. This is just something to know is out there. I won't go through it in detail. And then lastly, hypertension is kind of a mixed bag. The best data that we have for older patients is based on this HiVet and SPRINT trials that enrolled patients over the age of 75 in SPRINT and over 80 in HiVet, and showed a mortality benefit associated with targeting blood pressures below 150 over 80 in HiVet and below 120, a more aggressive treatment strategy in SPRINT. These studies, however, didn't include patients with dementia and severe comorbid diseases. And so we really don't know how best to treat our sickest elderly patients in terms of hypertension. These are some recommendations from ACC/AHA and then ACP. Have different targets for older patients, but basically there's just not enough information out there to guide treatment for our oldest, sickest patients. And so I think phoning a friend, talking to a geriatrician or your pharmacist are all reasonable things to do. Patient has complex cardiovascular disease, making changes in concert with their cardiologist is a wise thing to do. And then a couple of just general recommendations would be to check orthostatic vitals before starting any new blood pressure med. Avoid central alpha blockers like clonidine, peripheral alpha blockers like doxazosin, prazosin, terazosin, and then certainly avoid loop diuretics for patients without CKD or if you're not using it for volume management. I have a slide on overactive bladder, but this is just based on American Urologic Association recommendations, which are available on the internet. But basically, oxybutynin is not all that effective, and it has bad cholinergic side effects. And so use it really judiciously. And first-line treatment is behavior changes, which have been shown to be equally effective to oxybutynin. And then I will say incontinence is rarely fatal. And so having a conversation about your concerns about risks of oxybutynin and maybe preferring to use diapers or things of that nature, obviously significant like morbidity associated with that, and social consequences can be quite profound. But if you're really worried about harms in a patient taking anticholinergics like oxybutynin, it's a conversation worth having. There are new medications, beta agonists, mirabegron and vibegron that can be helpful in these situations too, that don't have the same anticholinergic effects. I'll stop. I'm over time. I apologize. Thank you guys so much for your time. And I'd be happy to take any questions that you may have. I briefly want to thank Dr. Amy Thomas and her colleagues, Benson Wong, Jen Tanoa, and Mandy Olney.
Great. Thanks so much, Thomas.